evening, everyone. I'm Tracy Scope, Manager Health Education, Programs and Services at the Lung Health Foundation. Welcome to Severe Asthma, What That Looks Like in Primary Care with Dr. Kaplan and Jennifer Faulkner, presented by AstraZeneca Canada. Before I introduce our speakers, I would like to go over some housekeeping. This session will be recorded and a link will be made available to all registrants. We ask that you please remain on mute during the presentation. There will be a Q&A after the presentation where you can come off mute to ask questions or use the chat function to ask your questions. Tonight, I have the pleasure to introduce our two speakers. Dr. Alan Kaplan is currently a family physician practicing in York Region in Ontario. He is the medical director of the Lynn Pulmonary Rehabilitation Clinics and is a chronic pain community consultant. He is also the Regional Primary Care Lead Central Region Cancer Program. Dr. Kaplan is the chairperson of the Family Physicians Airways Group of Canada and honorary professor of primary care respiratory medicine of the Observational and Pragmatic Research Institute, Singapore. He is also a Senate member of the International Primary Care Respiratory Group, Vice President Respiratory Effectiveness Group, and member of the past Canadian Consensus Guidelines for H. pylori, asthma, COPD, and sinusitis. He is also a co-chair, Health Quality Ontario, COPD Community Management Standards Committee, and member of the Health Quality Ontario Asthma Community Management Standards Committee. Dr. Kaplan has written over 500 newsletters, 151 peer-reviewed articles, and 110 conference abstracts. Jennifer is a 63-year-old retired letter carrier. She is a mom of 4 and nana to 5 awesome, fun grandchildren. She enjoys kayaking, hiking, and waterfall following. She has tried golfing, but claims she's not very good at it. She also snowshoes, zip lines, and most recently has taken tennis lessons with her youngest daughter. Again, she claims she's not very good, but she has a lot of laughs. And with that, I will now hand it over to Dr. Kaplan.
Tracy, thank you. And Jennifer, I think I'm just sounding jealous of all the things you're into. It's wonderful. So welcome, everybody. I know we have a varied group of different clinicians as well as caregivers. We're going to talk about severe asthma tonight. Here is my conflict slide. I work with just about every company that makes anything inhaled. I'm also involved in a number of government programs there, as you can see. And this program was sponsored by AstraZeneca, but they actually had no involvement in anything to do with my slides. They were on my own creation. So we're going to talk about today really what severe asthma is, how we assess it, talking about severe versus uncontrolled. We're going to talk about the burden of oral corticosteroids and why it's so important that we actually get people treated and not depend on oral corticosteroids. We're going to talk about how to refer for those primary care physicians in the group who may require a referral to access things like biologics we'll come to. We're going to talk a little bit about the biologics to make them relevant for us. We'll talk about a few tools to help us manage and identify patients who should be considered for this condition, for these things. So we see a lot of asthmatics. It's one of the most common chronic diseases we actually have in our practices. I'm sorry to bother you, but if someone's on, please, if you could just go on mute. It'd be hard for people to hear otherwise. So I appreciate that if you could do that. So this gives you an idea based on Gina last pocket guide, an idea roughly how many patients have both, first of all, severe, have step 4 or 5 asthma, which is considered fairly important asthma. And then from that group, we say how many actually have difficult to treat asthma, which means once you get on the right treatment, they're still not doing very well. They're still at poor control. And of that group, we're really talking about 3.7% actually have severe asthma, which is step 4 or 5, on therapy, good adherence and good inhaler technique, and still not controlled. And this is from a Dutch survey. There's no reason to think this is going to be any different in North America. So the bottom line, we talk about how many people actually have severe asthma of our asthma population. We sort of use a number of around 5%. Tracy, I'm not sure if you can mute the participants from your end, but I'm sure that's not helping people hear what I'm having to say. So a few different terminology. Severe asthma is asthma that's uncontrolled despite doing everything right. We've maximized our therapy, we've treated the comorbidities, We've removed our triggers as best possible. We're adherent to our medication. And even worse than that, or in addition to that, if you actually cut back treatment, asthma gets worse. Difficult to manage is difficult to get control based on either the perspective of the patient or the actual physician or the patient's family. And there's two main groups: people who have been controlled but now are not, or people whose asthma has actually never been controlled. And this is not new stuff. This is 2014 work by Chung. So it's not a new idea, but we've had so many new treatments now that it seems to be more exciting every day. So the reality is that we have a group of people who have poor symptom control. That's one group. The other group of people have frequent exacerbations. As you know, people who are poorly controlled tend to have more likely to have exacerbations. They're more likely to have severe exacerbations, which means they end up in the hospital, the emergency department, or the ICU. They required oral steroids and antibiotics, potentially. And despite the fact they've been treated, they continue to have airflow limitation. They have a reduced ratio. And for those of you that are into lower limit of normal, on the right side there, we have a picture of the lower limit of normal, which means that if we just take a ratio, and older people tend to get stiffened lungs, and therefore the ratio can be low because of age. So if you actually can calculate based on a lower limit ratio, which you just take that 5% out, and that's the ones that are considered to be below normal, then we can be a little more accurate in those people at extremes of age. But for the most part, we just look at the ratio as a measure of obstruction with spirometry. So in 2021, Dr. Connie Yang was the lead author of the CTS asthma guidelines. What they looked at here mostly was looking at the milder asthma. And so that's really the focus was of this particular guideline. But they did make some important changes. We've aligned with GINA, the Global Initiative for Asthma, to say that we want to have symptoms and SABA use less than twice a week. We want to have nighttime symptoms to be mild, at worst, if they occur at all. We don't want any missed work, school, life opportunities. We don't want to have exacerbations. So basically, we want our patients to have a completely normal life with only the very minus interruption based on asthma, not having it something that people use a lot of rescue for and being bothered from it and miss opportunities. So if you have all those criteria, you have well-controlled asthma. So there's a number of different ways to measure asthma control. We can just ask those questions, which is great. There are some formalized tools that have been validated. The asthma control tool is a test for over the last 4 weeks. And the higher the number, the better the control. So you can see in the last 4 weeks how much of your asthma just stopped you from getting stuff done, how many times you had shortness of breath, have you had wheezing, coughing, shortness of breath, have you had to use your rescue inhaler or nebulizer. Of course, this is initially started outside of Canada, where nebulizers get used a lot, which is most of the United States. And how would you rate your own control over the last little while? And this is a tool that gets used in the study. What's very interesting is actually if you follow patients and you treat them so that their asthma control test improves, we actually see a real significant cost saving in terms of how much is spent on the system. And this is in euros, done in a European market. But you can see that actually it's not just a thing about getting people to feel better and be controlled. It actually saves them costs in the healthcare system in terms of exacerbations, prednisone, and stepping up therapy. So quality of life is also improved. So the message here, the thing we want, is for patients to be controlled. And if they're controlled, they do better on every status. Another questionnaire is called the ACQ, the Asthma Control Questionnaire. It's 7 questions over the last week. And again, here we have that the higher the number, the worse it is. And you're well controlled if your score is 0. So again, are you woken by your asthma? Do you have symptoms when you wake up in the morning? Are you limited in activities? Do you have shortness of breath? Do you wheeze? How many times do you use your short-acting bronchodilator? And the ACQ 6 is those 6 questions. The 7th is adding in lung function. And if your lung function is normal, then that score is low as well. So we have a number of different issues there, and this is measured over the last week as well. So again, the definition of severe asthma based on Dr. Cheng's measurement in 2014, which goes back ERS and ATS combined assessment, says they have a high dose ICS and a second controller for the last year, or they've needed systemic steroids for half of the last year to stop becoming uncontrolled, or despite adequate therapy, everything we've done, we continue to be uncontrolled. So if you think about our patients that are uncontrolled, we want to do some basics first to make sure that we haven't done everything else, and then we land on this difficult to manage or severe asthma. I'd like to introduce Jennifer to you, and you've heard her talk about herself a little bit at the beginning. And I put up some slides here about what her story is. We're going to meet her now. She's going to tell us her story, and then we're going to come back to Jennifer at the end so she can give us some tips and what we can do to make sure stories like Jennifer don't happen in the future. Although it's a happy ending, I'm very happy to see. So Jennifer, on to you.
Hi there. I never had asthma as a child. When I was in my late 20s, I started getting upper respiratory infections, and I would go to my doctor, my GP, and he would give me a round of antibiotics, a Ventolin inhaler, and a short burst of prednisone. And that happened, occasionally. And then as time went on, it was happening more and more often and more often, to the point where eventually, and at no time when I was with my GP was I tested. One night, it just got to the point where I would call the doctor's office and say, I'm having problems breathing. And they'd say, come on in. They'd give me the nebulizer. They'd give me the prednisone. And one night my doctor wasn't available. And I saw another doctor, and she said to me, how long have you had asthma? And I said, I don't have asthma. And she said, yes, you do. Well, I was still just seeing my GP. I'd never been tested. I had no idea. So this continued on for a while. And fast forward, I was a letter carrier. So I was out carrying 40 to 45 pounds of mail, up hills, down hills, in really cold weather like we've got today, in very humid weather. And one day I went to my boss and I said, I know I'm going to have a problem breathing today. Could you give me some help, cover part of my route? And she said, no. And of course I did have a problem, and I did end up back at the doctor's office. And he wrote me a note to take into to the work that said, Jennifer has severe asthma. And I had no idea. And still, I have not been tested for anything. He eventually did refer me to an asthma specialist. But by this time, I was on prednisone probably 5 to 6 times a year. I was on Pulmicort, I was on Symbicort, I was on Spiriva. I felt like a walking medicine cabinet. I was extremely, extremely lucky, or she felt at a loss and didn't know how she could help me anymore. She referred me down to the Firestone Clinic. And as the slide shows there, her hope was that I would be a candidate for bronchothermoplasty. I was not. And I kind of was really distraught then. And I was surviving. I wasn't enjoying life. I wasn't living. I was surviving, getting through day to day. And then I was lucky enough to get in a drug trial for one of the biologics. And it was like somebody flipped a switch, and nothing can stop me now. I am off all of my medication except for the biologic, which I take once every 8 weeks, self-injection, and one puff of Spiriva or Symbicort twice a day. And I would almost say I'm cured. I know I'm not cured. I know if I don't have that biologic, that I will go back to surviving.
So really the story of really someone who's suffering, who's actually lost hope, but then was fortunate enough to see one of the leading Canadian respirologists, Dr. Param Nair, and got started on a biologic, an anti-IL-5. We'll talk about the choices there. Actually, it's an anti-IL-5 receptor. It's a bit different than the others. But, great drug that decreases the eosinophils and basically treated the inflammation. And now Jennifer is doing fantastic, and she'll share with you all the things she gets into in a little while. So the messages here are, number one, is that we actually need to make a diagnosis. And number two, we have to listen to our patients who are suffering. And number three, we have to recognize that we actually have new options for treatment, and we should make sure it's available for our patients. So how do we differentiate uncontrolled from severe asthma? Well, the first step, as Jennifer said, was confirm the diagnosis. We need to make a diagnosis. There's lots of reasons people can have wheeze and shortness of breath. It's not always asthma. So the first is doing spirometry, because asthma is a variable disease. Sometimes it's normal, although someone who is as sick as Jennifer probably wouldn't be normal. But sometimes you have to move on to things like methacholine challenges to see it. And the analogy there is, if someone has angina and we do an ECG at rest, it can be normal. So you put people on a treadmill and you exercise them, and then you see the changes in the ECG. So similarly with asthma, the spirometry may be normal at baseline, but you stimulate it with a challenge test and the FEV1 drops showing you that there's bronchial hyperreactivity. The next is to look at the basics, which is the medications that have been prescribed, are they being used? And it's quite remarkable, and this doesn't surprise many people on this call, that people stop taking their medication as soon as they feel a little bit better. And that's been shown in endless numbers of studies. So the next step is are patients actually adherent? And of course, it's completely human nature. I get it. You feel better. Why do you want to take a medication? It's got that steroid stuff in it, so I don't want to take that. But that's really what happens. And then just take the SABA as they need it, because that makes them feel better when they need it. So these are problems that occur. Inhalation technique is a huge issue. You know, and a couple of basic premises here, that if you're using a dry powder, you as the patient using it have to suck hard to activate the device. If you're using an MDI, the MDI sprays and it provides the power. So the MDI you want to inhale very slowly. The soft powder, the dry powder, you have to inhale very quickly. And then there's environmental issues, what you might be allergic to, what might be triggers. Is it someone smoking? Is it you smoking? Is it an occupational situation, which you should consider in adult asthma? You know, is it grasses, trees, pollen, ragweed, all that kind of stuff that's doing it, and treat that as best we can. Then we want to rule out mimickers, and I'll describe a few of those, but there's many conditions that look like asthma, there's many conditions that worsen asthma, and there's many conditions that can be concomitant to asthma, and we've got to go through that as well. And then if we're well controlled and we stepped up to intensity treatment and we're into that trouble, then we have severe asthma. And then as people with asthma specialization, we'll then do tests to phenotype the patient to decide what might be the best alternative for treatment after we stepped up therapy to dual therapy, or now even triple therapy that's available. So there's just LABA, LAMA, ICS all together in one inhaler. There's two of those now in the Canadian market. So here we have a situation where we've gone through all those steps, and now we want to figure out which is going to be the best potential biologic for them. So before we go into that, you know, what is considered asthma control? And this is an article that I wrote in 2008, and it's still perfectly appropriate today. So is the diagnosis correct? Is the adherence proper, and then why? Is it concern versus necessity, that I don't think I need it, I'm not that concerned about it, and so on. It's intrusive taking medication regularly. There's a stigma to saying, hey, it means I have an illness, don't want to admit that. Inhaler technique I've touched on already. Concomitant illnesses, and the two big ones are going to be rhinitis, upper airway disease, as well as gastroesophageal reflux disorder. But there's more and more work on other things, including things like obesity. And I think you're going to hear a little bit more obesity and asthma in the next little while. I just actually finished writing an article about that recently. Triggers like in the environment, whether it's the dog and the cat or the outside allergens, but also, of course, smoking. And smoking is more than just an irritant. It actually deactivates an enzyme called histone deacetylase and makes inhaled steroids not work as well. And is it the right therapy for that person? And is it something that we actually have to think about what phenotype they have so we can particularly personalize their therapy? So that's where we are. So first step, confirm the diagnosis. Spirometry, pre and post bronchodilator, and that's the first step. But if someone's symptomatic and the spirometry does not show obstruction, it's probably not asthma. If they're asymptomatic, right, so again, the situation where they're fairly quiet, then the bronchial challenge, methacholine challenge, things like that would make sense. But it needs to be done. And I recognize that COVID has put a bit of a monkey wrench in this. A lot of spirometry places were closed because of being an aerosol generating procedure. But now, for the most part, they're starting to open up. We can get spirometry. I know for myself in my office, closed it during the alpha wave. I opened it up after the Delta wave, and I closed it again for Omicron because of the increased infectivity of Omicron. And we started it back up again, and we're just a little more careful. We don't do as many tests in the day. We make sure that it's in a room that's well ventilated. If we're not sure, we make them do a rapid test first. As many things as we can to be safe for both the patient and the staff. And my staff, when they do it, are wearing an N95 and they're gowned up to protect them as much as possible. So these are all the things we want to make sure happens. Now, why is diagnosis so important? So Sean Aaron, who's a brilliant respirologist at the University of Ottawa, was the lead author on this trial. What they did was they made those phone calls that everybody hates at dinner time, saying, do you have asthma? And if the people said they had asthma, they said, would you be interested in being in a study? And if they went into the study, then they went through a number of steps. So they had spirometry. If the spirometry was normal, then they said, stop your medication. And if they were sick, they restarted the course, but otherwise then they did methacolanes, and they moved all the way up to seeing some of the different specialists who were listed on there across the country to decide if they had asthma or not. Some of our leading Canadian respirologists. And what they found is that a not insignificant number did not have asthma. And 2% actually had conditions that actually could be quite serious, like coronary artery disease, subglottic stenosis, bronchiectasis, interstitial lung disease, tracheobronchial malacia, all things which are mimickers of asthma potentially, but weren't asthma. So there's a lot of other conditions you can see on the left that were also part of the problem. People are coughing to the ACE inhibitors. Sometimes they just were unfit, and that's why they were short of breath. Sometimes hyperventilation, which actually could cause people to feel short of breath and make them feel they got asthma. So there's a number of things it could be. So the first message, of course, is make a diagnosis. And guess what? Those patients that were misdiagnosed with asthma, the commonality about all of them is they never had spirometry done. So that's what's happening out there in the community. So the next, again, is looking at technique and the environment and adherence. Adherence is tough. You know, you ask someone, are you taking your medication? They say, of course I am. You know, and then if you check with the pharmacy, well, how many inhalers did they actually get this year? Well, they picked up 2, and that should last about 4 months. So we know that hasn't been taken. So we don't want to be confrontational, but the reality is people often do not take their medication regularly. We can do testing of the environment with things like skin prick testing and serum IgE testing to look at these air allergens that may be there. And we can get quite fancy and do specific challenge tests with inhalational tests for people with things like occupational asthma, where you're trying to specify what it might be. That's going to usually need a referral to someone with an interest in occupational asthma. And of course, observing the technique. And I think that's the important thing. Don't just get people to describe it, get them to bring their inhaler, and you watch them use it. And I know not all of us are comfortable with all the inhalers. So here's a tip. If you know what inhaler they're taking, before they come in, open up the YouTube channel or look at the Family Physician Airways Group of Canada website, where we have a tool section that talks about inhaler devices, or the Lung Health Foundation has this as well, and have a look at a video that shows how to use the inhaler properly. And in 30 seconds to a minute, you'll be an expert, and then you can watch patients to understand if they're using it properly. How common of a problem is adherence? Well, this is some Brogan data, and it's not a new trial now, it's 2005, but it's still the same today. And what you see on the left is, it doesn't matter which color inhaler the patient started with. At 3 months, most of the people do not repeat it, and by a year, less than 20% of people are still taking the inhaler. So adherence is a very, very common problem. And there's a lot of factors here. You know, it may be that the patient's just not comfortable using the inhaler, it's not working well, so they stop taking it. Maybe there's some cognitive issues. And actually, long-term asthma therapy has actually been shown to affect the hippocampus. So uncontrolled asthma is actually also not good for the brain, something that people don't know about. Right? Do they have a preference for an inhaler and we force them to change? That's a bad idea. So you're going to hear a lot about climate in the next little while, where we should be changing everyone from an MDI to a BPI. And while that's good for the carbon house gases, it may be actually very bad for the patient who then uses the medication improperly, is unhappy. We don't want to mix inhalers, by the way. That's important. We don't use a dry powder and a slow and a MDI together, because one is as slow as you can, one is as fast as you can. You know they're going to mess it up. How many times do they have to take medication a day? Is it 1 time a day? Is it 4 times a day? When I started practicing, it was Beclovent 4 times a day. Guess how the adherence was for that? Not very good. And do they know which one's which? They know that the brown one, the orange one, the red one, the purple one is the controller, and the blue one, or potentially the red one, are relievers. Do we actually know which one's which? And people actually get them mixed up, which of course is a disaster. So yeah, the patient factors are the perception, potentially. Many people have symptoms for a long time, and they just accept that as their normal. They may have a perception about medications and their belief necessity issues that I actually don't believe it's that important. I don't believe I really need this, and therefore I don't want to take medication. I've talked about stigma. Obviously cost is an issue, and a lot of people say, I'd just rather take the blue one because it works. And we know from evidence that I'll show you that the more you take a blue, the worse you do. So the answer to this, of course, is shared decision-making. And the concept of shared decision-making is that you have a conversation about the problem, you give choices, you discuss the options, and then you make a decision together, the healthcare worker and the patient, to make that issue. So there was a study done by Wilson in 2010 that looked at that, and they had 4 extra steps to the encounter. They identified what the patient wanted. We summarized back to the patients what it is they wanted and got the agreement. We talked about the different choices of the treatment plans and had agreement on what we wanted to do. And those were the 4 steps. And you know what? With no change in medication prescribed, the outcome here was incredible, because the patient bought into this conversation and decision and treatment strategy. And we decreased the use of We increased the use of controllers. We decreased the use of SABA by 1.6 canisters in a year, which is a ton. Improved quality of life, improved the likelihood of having well-controlled asthma, and decreased exacerbations just by talking to the patient and working with them to come up with a plan. Now, as a clinician, this doesn't always work. Sometimes the patient says, no, I don't want to take anything. I just want to have a SABA. And then we got to turn that around to find out what is it they actually want in their life, and how and will a SABA actually solve that for them? Well, I do not want to ever go back in the hospital again. Well, unfortunately, the SABA is not going to solve that. So you want to rethink it. And you've got to get it to be the patient's idea for it to work. And those are the steps you have to take. So talking about the SABA, here's one of the Sabina trials. And with the Sabina trials, where they looked, and this was in Sweden, but they've done it in the UK, they've done it in Canada, they've done it in a number of places around the world. It's all shown the same thing. So in databases, they looked at number of SABAs used, and they compared it to outcomes like exacerbations and mortality. So you can see here that it didn't matter which treatment step. So step 1 is mild disease, step 4 is more severe disease. But if you use 2 or less, that was your baseline. If you use more than 3, your risk of an exacerbation was higher. Doesn't matter on what baseline therapy. So the more SABA you use, the worse the outcome in terms of exacerbations. But here's scary. Also, the worse the outcome when it comes to death. So there's a risk of death from asthma. We don't like talking about that, but every year we have about 250 people in Canada who die of asthma, and that should never happen. It just should never happen. We have too many really good drugs and treatments and clinicians out here to support our patients. It should never happen. So it does happen, and it happens frequently in the context of SABA overuse. And that's not saying this is what's happened here. This is just a relationship based on a database trial, but quite clearly, more SABA use, the more likely you are to die. Here's the Canadian data. This is done from a database in Nova Scotia and Saskatchewan. They looked at this, and again, you can see that the more SABAs you use, the more likely you were to have an unscheduled visit. But more importantly, 60% of people who are using 3 SABAs or more had a course, 60% overall had used 3 canisters or more, and almost 40% required oral steroids at least once in that year. We'll talk about the dangers of oral steroids. So this is a big deal, and this is not just those other countries, it's in Canada. We have this issue of SABA over-reliance. Here's some Ontario data. I apologize for people who are outside of Ontario, but I suggest that it's as bad, if not worse, than some of the other provinces, but I don't have hard data for it. So this looks over a number of years and how the beta agonist use was worked, some work done by Teresa Toe's group. And what you can see is that the good news is people with less than 4, those numbers have gone up over the course of time. And for the most part, the ones who are more frequent have gone down a little bit. But if you still look at this, you can see that over 20% use 5 to 12 canisters per year. And a certain smaller percentage are using more than 20. So we have a problem of SABA overuse and SABA over-reliance in Canada. And I've already talked to you about what those numbers mean in terms of exacerbation risk and mortality. So we want to change that. We want to get those down to less than 3. It's really the answer we want to have. It's a tool that we created as part of the Asthma Right Care. And this is an international global group that we created as part of the International Primary Care Respiratory Group, which is a group of primary care organizations for which the Founding Physician Airways Group of Canada was one of the founding members. And it was done in conjunction with 4 or 5 other clinicians, as well as a psychologist named Rob Horn, who's very into respiratory medicine. And we created this tool, and it's been validated. It's been done now around the world. And the concept here is it's a 1 to 5 score, and what's the attitude of the patient towards their SABA? So the blue inhaler is the best way to keep on top of my asthma. I don't worry when I have my blue one around. My blue one is the only one I can really rely on. If the blue one risks are outweighed by benefits, and I'd rather use my blue one than my steroid one. You can see the higher the number, the more likely it is to be over-reliant. Now, if you don't want to look at this way and do this whole tool, you look at people's arms and you see tattoos, or the chest and see tattoos that says, it ain't easy being wheezy, and putting blue puffers on their body. I don't get tattoos particularly, but I can understand the loved one or a saying that's important to you. But if what's the most important thing in your life to tattoo your body with is your blue puffer, you've got an over-reliance on your blue puffer. And that blue puffer over-reliance comes by very, very innocently. So what happens is the patient comes into the clinician and says, I can't breathe. The physician says, here, take some puffs of this stuff. And 5 to 10 minutes, you're feeling better. You're not wheezing, you're not short of breath. You say, wow, this stuff is amazing. I want some of that stuff. And I actually do not ever want to be without it again. And that's that relationship that people have with SABAs. And we actually have to think about breaking that. We'll talk a little bit about that. So this is another article that looked at patients' healthcare beliefs with respect to adherence. What did they actually do in this group? Well, they use it twice a day every day, and about 40%. Some days they use it twice a day, other days I don't use it, another almost 40%. I used to use it, but now I don't, and 20%. And some said I never used it. The doctor gave it to me, but I never actually used my steroid inhaler, right? And what's the reasons? I only want to use it when I need it. I don't want to use medication unless I feel sick. I don't want to use steroids. I feel fine. I don't need it. I don't like side effects. All very reasonable reasons to be concerned. But the other half of this is, if you'd like to breathe, if you'd like to prevent further lung damage, if you'd like to not have a hospitalization or risk of mortality, we need to treat our medications. So overall, the 3 factors in adherence, again, is this motivation. First, you got to listen. We have to listen to what our patients are saying and understand where they're coming from. We have to build trust and empathy, and remember what it is they said. We have to understand where they're coming from, and we have to get them to understand what the risks are of inadequate treatment are, so that we can hopefully motivate them to be involved in the treatment plan that we're agreeing on. And then once we decided that, there's going to be some real barriers, and the barriers can be cost, it can be attitude, it can be family. So we have to work through those kind of things to try to understand what they are. So what are their beliefs and what are their barriers? In terms of adherence, I do particularly find this is a challenge. It's hard to do it. You ask the patient, they say they take it. You ask the family, you may get some truth. Get them to bring their inhalers in and do the math. How many inhalers have they had? How many puffs are left? Watch them use it. Again, if they don't know how to use it, they're probably not using it. So if they can barely get it out of the package properly, you have an idea they're not taking it. Then we contact the pharmacy and get fill rates. Because in some places in the country, you can actually go online and check the actual pharmacy records. Can't really do that very well in Ontario, but in BC you can do that, and Alberta and Manitoba you can do that. So under understanding that the communication between the healthcare practitioner, and that doesn't just mean the doctor, it means the pharmacist and the nurse practitioner and and healthcare workers that are involved, as well as even the family and the patient, have to be able to communicate. I'll move on from that concept and talk about some other ideas that have been used to try to improve adherence and help us get an idea overall. And you're going to hear more about smart inhalers. These are inhalers that have a digital mechanism on it that measures the dose being taken. Some of them will measure things like inspiratory flow to give an idea that's been used. Then you get data on the medication just given to the patient on their handheld, and can also be sent to the healthcare professional to keep an eye on these things. So with this kind of adherence, with sort of Big Brother sort of looking over, even if it's just you checking your results yourself, that makes a difference potentially in the use of medications. So more and more medications are going to be coming as smart inhalers over the next little while. Talked about comorbidities, the big ones we talked about already with rhinitis, reflux, and obesity. We recognize this can be manifested also in anxiety, and that can change people's effect of how they experience their disease. Vocal cord dysfunction is paradoxical vocal cord movement. That's an alternative diagnosis. It often happens in people who have concomitant asthma, and it requires a different kind of treatment where you have to teach yourself how to breathe. And of course, there can be other conditions like polyps. There can be allergen exposures and work-related asthma and different inflammatory conditions that are infectious and non-infectious, all of which can make it very difficult to assess. So you've got an asthmatic that you've treated by something that should work. They're taking their medication, they're taking it properly. You've looked at the ordinary stuff like upper airway and GERD, and they're still not doing well. Maybe it's something else, and maybe that's the time you're considering getting a consultation, because they could have a whole bunch of these mimicking conditions. So the obvious ones you're familiar with are going to be COPD, interstitial lung disease, which connective tissue disease can lead to. They can have immune deficiency leading to recurrent chest infections. You can have aspergillosis. There's a number of conditions there I won't get into. But the bottom line is, when things aren't going well, it might be something else. In addition, not all patients' triggers are the same, and triggers in people's lives will change as a pet may pass away or you get a new pet, different seasons and so on. Feathers in a jacket. Many things can do this, and I won't go all the list through here, but again, this is important. Of course, aspirin-associated disorder can be an issue with aspirin sort of allergy and polyps that go together. So there's a lot of things that can cause trigger, and we have to recognize that. And then the conversation has started to happen about the different phenotypes of asthma. This is some work done by Sally Wenzel going back to 2012. It talks about the T2 versus the non-T2. Now we call that low T2 disease. And the classic asthma is allergy, high T2, high eosinophil, high IgE. But even in their exercise-induced asthma, which is a little bit more complicated than that. There's the asthma exacerbation-related disorder, and this eosinophilic disease that starts later in life, which sounds like is what happened to Jennifer. She did not have asthma as an adult. She had this as getting a little bit older. It's more common in women, so it's not a surprising story. So she fits in that orangey colored circle there. Then there's a non-T2 that is not associated with markers of inflammation, not associated with bloody eosinophils, sputum eosinophils, fractionated cell nitric oxide, and so on. It can be related to obesity. Again, it can be related to later onset in women related to non-eosinophilic disease. It can be smoking associated. And there's some people that actually have very low inflammatory cells at all if we actually measure them with things like sputum eosinophils, which is only really done in 5 or 6 places across the country. Jennifer was lucky enough to go to Firestone where they actually do this as a research tool. So clearly, once you've got to the severe asthma, it can be any of those different groups, and we have to work them up for it as clinicians. The good news, if you're primary care clinicians, I don't really expect you to do that. I expect you to actually recognize these patients in your practice and get them referred out. You can certainly do the biomarkers. You can do a serum IgE. You can do allergy testing. You can do a CBC with a blood eosinophil count. Okay? I actually do FeNO in my office, fractionated cell nitric oxide. You're blowing a little machine, and it gives you a measurement that's a surrogate measurement of eosinophilic inflammation. But for us in primary care and for the patients out there trying to figure it out, we either have symptoms that are concordant or discordant. And the common is concordant. A lot of allergy, a lot of asthma. Discordant, they have a lot of symptoms, but they don't have a lot of inflammatory mediators. Discordant, they have a lot of inflammation, but don't have a lot of symptoms. So again, we're trying to figure this out. And the more discordant, the more it is to be refractory asthma. The more concordant, the more it is the medications we're going to use will work. Like I said, there's different cell types. Details are not important, but we have eosinophilic, we have neutrophilic, which is often related to infection. We have mixed disease, and we have those with not much cells at all. They just have thickened basement membrane and thick and smooth muscle, and that's where the bronchioplasties can actually work well. Fortunately, that's not what Jennifer needed. She had high eosinophils, and she was treated with an IL-5. But here's the biomarkers. So we look at sputum eosinophils where you can, but it's not a prerequisite for treatment of biologics. We tend to use that more for people who are actually in those centers or people who things aren't going well. We need to assess this as such. So I'm in Aurora. The drive to Hamilton's not that close. So I send a few people there a year who I can't quite figure it out without doing that test. We all have access to blood eosinophil counts. That's in the bottom of your CBC, in the part you never look at. It says eosinophils. It'll say 0.3, and that's 300. And 300 is that magic number for which we have increased worsening asthma outcomes the higher the blood eosinophil count. FeNO I mentioned, and the different biomarkers are used to predict the efficacy of different drugs. And I'll get into the drugs in a moment. But blood eosinophils is pretty central for the IL-5 as well as the IL-4 and 13s. FeNO is more essential for dupilumab. That's how its testing works. And the new drug, tezepelumab. And omalizumab, the oldest one around, Xolair, that was dependent on allergy testing and serum IgE. The periostin story has closed out. IL-13 on its own did not work, so we don't use periostin. Here's some work that I did with David Price, who's one of the most published people in the world and works in OPRI, Observational Pragmatic Research Institute. I do some work with him. And the work that we did is we looked at the blood eosinophils, and you see that the higher the blood eosinophil, the more likely you're going to have an exacerbation or respiratory event, and the less likely you are to have good control. So these are database trials, not looking at individual people. But again, the higher the blood eosinophil count, the more likely your patient is to get in trouble. And it's a marker for us to say, hey, what are we going to do about it? Now, this is the part of the asthma confusogram. And I'm not going to test you at the end of this, but I just want to give you an idea of the complexity of the different cytokines that are involved in asthma management and how, while we didn't have this very clear a number of years ago, I remember being shown this at a conference by a well-known American respiratory specialist, Michael Weschler, and he showed this at a conference, and I went up to him afterwards and said, well, can you send that to me? Because I didn't understand that. He was actually kind enough to spend 20 minutes with me explaining it at the time and then sent me the slide. So what happens here is that we have the eosinophilic pathway. So there is an allergen or irritant or an infection that causes inflammation to be started as it goes through the upper part of the epithelium there and gets met up by thymic stromal lymphoproteins, ILC2 cells, which then releases these cytokines, or IL-4 to release different cytokines. And the eosinophilic pathway this goes based on eosinophils. Eosinophils Messages are sent to the bone marrow to create more eosinophils. There's more eosinophilic inflammation through the interleukins, the cytokines of IL-4, 13, and 5. Then we look at the allergic pathway, and that's the Zoller pathway. Again, same cytokines, IL-4, 13, and 5 involved, but they end up stimulating B cells to release antibodies, and that's the IgE. And when IgE meets up with the allergen, it goes to the mast cells and releases histamine and serotonin and leukotrienes and causes the whole problem. So it's a little lower in the pathway, as you can see. And then we talk about the FeNO pathway. So FeNO, is also released from that airway when things happen to the epithelium, fractionated cell nitric oxide, part of the inflammation. It's actually a surrogate measurement of eosinophilic inflammation, but it's a measurement we use. And again, based on that, we get an idea that the IL-4 and 13 may be the predominant cytokines involved, and we aim for IL-4 and 13 for that. So all of these are different parts of type 2 inflammation and asthma, and they all have slightly separate pathways, but they're also, as you can see, all very interrelated, and that makes it, of course, quite complicated. So FeNO gets released back in when you measure when IL-4, 13 is stimulated by T2 inflammation, and it can be measured by a little machine that we talked about already. And there's a lot of utility. The higher the number, the more likely they are to have eosinophilic disease. And we also use it for adherence, but we use it as a biomarker for the IL-4, 13, whereas we use the blood eosinophil count for the IL-5s, right? So this gets worked on by a lot of drugs, including the newest kid on the block, which is TSLP, which I'll talk about in a minute. So a lot of different drugs. I'll show them to you in primary care. Unless you're actually going to get involved in treating severe asthma and doing these measurements, you really don't have to know them. But again, we'll group them up into the IL-5s. First of all, the anti-IgE, which is omalizumab. And again, the biomarkers are associated with both elevated blood eosinophils and FeNO, but the big thing is having allergies and having elevated IgE. Right? It also has an indication for polyps and also for chronic urticaria, for idiopathic urticaria. Mepolizumab and rezolizumab are anti-IL-5. Benralizumab is an anti-IL-5 receptor. They all work fairly similarly. They all reduce exacerbations. They all work better the higher the blood eosinophil count. Benralizumab, because it affects the receptor, actually does a much better job at lowering the eosinophil count down, which is thought to improve its efficacy. And the injections, as Jennifer said, she now gets injection every 8 weeks. Benralizumab is every 4 weeks for the first few doses, and then it's every 8 weeks. Everything else is probably every 4 weeks. Zoller is every 2 to 4 weeks, depending on the weight and the IgE level. So lots of choices there, and we pick them based on some of these factors. We pick them based on some of the comorbidities that they treat. So for instance, dupilumab has indication for atopic dermatitis and nasal polyps. Benralizumab has also for nasal polyps. Mepolizumab has also for nasal polyps. And a group of them there work for EGPA as well, another eosinophilic disease. So we have lots of choices, and there's some overlap there. So it's not that one's for sure the right for that person. We have a lot of overlap. Now, a lot of medications get used based on when they were introduced. So anti-IgE was released a good 15 years before the next one, if not longer. Then we had the anti-IL-5 and the IL-5R receptor, which I talked about roughly all at the same time. Anti-IL-4, 13 was after that. And most recently this year with the anti-TSLP. So we've had all these new drugs, and as clinicians, we're started using them more and more as we've got new drugs based on the indication. But in terms of experience, we have a lot more with Zoller, we have a lot more with the IL-5s than we do with the Dupixent or tezepelumab. So here's some of the comorbidities. I talked about that Zoller works well for urticaria, and that IL-5s work for nasal polyps and Sturge-Strauss, and 413 works for atopic dermatitis and nasal polyps, and also it's got a recent indication for prurigo nodularis, a particular kind of rash with big nodules. So this is going to make a difference also in what drugs we choose for the individual patient in front of us. So I just wanted to mention we had a question there about talking about SABA and introducing SABA as a first choice, changing that relationship. And the question asked was, what about using Zenhale as an MDI ICS lab instead? I think that's a very reasonable idea. There's no data for that. The only drug that we have data for that is the same idea in ICS formoterol, but in the form of budesonide formoterol, which is Symbicort, which has a whole bunch of trials, both in moderate disease, we call the SMART strategy, and mild disease, which were the Sigma trials, using ICS formoterol PRN and using it as the rescue. So I certainly understand the concept of using methadone formoterol or Zenhale, but it's never actually been studied. So it's hard for me to give that recommendation, although intuitively it does make some sense. But again, without any trials saying it works and no indication for it in Canada, I can't make that recommendation, but I understand it. These are the CTS severe asthma guidelines. They were led by Dr. Mark Fitzgerald in 2017. I always take a moment to remember Mark. Mark was a respirologist in Vancouver. He was a Canadian leader and a world leader. He was on GINA. We lost him about a year and a half ago. And not only was he a brilliant researcher and clinician, he was a friend, and I could always trust him for good advice across the years. So Mark, you're well missed, and I always want to take a moment to actually just remember you for what you've done. And he led on this particular initiative, which is now frankly out of date. But you can see here, assessment, environmental control, reliever, moving up to triple therapy. At the time, only tiotropium was approved as a LAMA in asthma. Now we have two others in triple disease. You know, omalizumab, IL-5, macrolide for people with low T2, long-term prednisone, which is a horrible idea, but sometimes people ended up on it. But now we have newer drugs. So this is going to have to be revamped with the newer drugs. Here's the GINA guidelines, and the preferred group is to really, as was mentioned by the earlier question, to start with ICS for model and not start with the SABA entirely. That's the preferred recommendation by GINA. And as people need that more regularly, they need to get on regular low dose ICS for moderate, stepping up the dose of the steroid until you get to the step 5, which is when you add in triple therapy, when you start considering biologics. The alternative pathways for people where ICS for moderate may not be available, maybe formulary, maybe cost, although in the long run, it's cheaper to use ICS for moderate than SABA and a reliever, but anyhow. And here the recommendation was you're going to use a SABA, but every time you take a SABA, take a puff of your controller, of your ICS, and that's going to give you effectively an anti-inflammatory reliever. So the concept is still the same for GINA. For CTS, it's a little bit different in terms of not doing that. But again, we're going to talk more about severe asthma here. Again, adding on a triple therapy, considering biologic. So Guy Brissell put this article in the ERJ, and it's just a nice breakdown of how you approach the different drugs. And really the point here is it doesn't matter which biomarker you use, there's a lot of choices depending on the biomarkers. So it's not that only one drug works for that biomarker, especially when there's multiple biomarkers. So they actually did a study in ISAR, the International Severe Asthma Registry, and they gave a bunch of super specialists a bunch of cases. And there's actually very little agreement on the treatment choice. And that's because there's a lot of options and they all make sense. There's no one right option, but there are better and worse options. And that's our job as clinicians, to find the best fit for the patient in front of us. So the new kid on the block is TSLP. And if you look, you can see that TSLP is right up at the top. Okay? And this anti-TSLP will therefore work on that. And because it works so high up in the cascade, it's thought to actually be more inclusive. And in fact, there is some evidence of such that is the case. I'll expand on it just a little bit because it's brand new and you probably haven't heard much about it. So it seems to work where the IL-5s and work best when the blood eosinophil count is high. The TSLP actually works even in situations when the blood eosinophil count is a little bit lower. When the dupilumab works best when the FeNO is high or the eosinophils are high. Tezi actually works reasonably well even when you have lower T2. And it doesn't matter about the IG level. So we have a drug with Tezi which actually may be effective for our patients with T2 low disease, whereas all the other biologics are really effective in T2 high disease, with a tiny bit of evidence for dupilumab working a little bit some of those T2 low disease. So as clinicians, we're saying, well, what is more likely going to work? We want to pick a drug that's going to be effective, and it may be that Tezi actually has a wider distribution in terms of efficacy. It also improves lung function, so that's nice because really in the first few weeks, you'll see lung function going up, which is a marker that says, hey, it's working. And some of the IL-5s don't do that as well. Xolair does not do that as well. Dupilumab does it actually not too bad. So I want to go ahead and touch on steroids. And the use of steroids for asthma goes back to December 1958 with Dr. Morrow Brown. And he actually showed that if you give people steroids and you do biopsies of their lungs, you actually see the eosinophils go away. Steroids are great. But oral steroids, not such a good idea. And using long-term oral steroids, like you saw Jennifer define too early, that she was using them regularly, can lead to a lot of side effects. Unfortunately, Jennifer did not have most of these. But there is a lot there. They're scary. I saw someone today who gets psychotic every time she uses oral steroids, increased risk of hypertension, cardiovascular disease, obesity, renal disease, osteoporosis, diabetes, fractures, cataract, glaucoma. It just goes on and on. And an edict from the CMPA years ago said that anytime a clinician writes a prescription for oral steroids, they must warn the patient of avascular necrosis of the hip dies. And if you don't and they get it, which is not common, but it can happen, you're going to lose that lawsuit. So again, clinicians, if you're writing oral steroid prescriptions, you must put in your note and tell the patient about the risk of avascular necrosis. Oral steroid bursts increase the risk of GI bleeds, sepsis, heart failure, DVT in different trials. So these are not benign medications, even for short-term bursts. And it's also associated when you use long-term oral steroids, systemic steroids, to an increased risk of mortality. So the more steroids you use, the higher risk of dying. That's irrespective of everything else. So again, these are not good drugs. Now, I've been criticized when I say this because I keep saying they're bad drugs, and I have people tell me, well, but they work for me when I need them. And yes, when you need them, you should use them. But our goal is to prevent the need of them. And now we've actually got a lot of different organizations talking about oral corticosteroid stewardship. We need to protect our patients from overexposure to oral steroids. And oral steroids is a treatment plan failure, not that it's not working as a treatment, but it's actually causing harm, and therefore we should try to avoid it and do everything else to avoid using it. The burden of oral steroids has gone down. The maintenance steroids taken every day has gone down in Canada because of biologics, but those episodic, getting a week or two prescription for a short course of oral steroids continues to be just as high as it always was. It's not coming down. I saw someone today who required that, and that's a big problem. So we need to try to fix this over time. Now, when you do stop oral steroids, clinicians, if you are involved in that situation, recognize there's some risks to stopping oral steroids. The condition that they're on it for could flare up, and they could have adrenal suppression, which could then lead to an adrenal crisis. So adrenal suppression has very non-specific side symptoms. They don't feel right. They're just not right. They're tired. They're nauseous. They have diarrhea. They're abdominal pain. They have a headache. They got through this symptom constellation. When you hear someone like this, and it just doesn't make any sense, then you're thinking about adrenal suppression. Adrenal crisis means they really needed a lot more adrenal hormone. They needed cortisol because of stresses. They have not enough, and they can die. They may prevent with hyponatremia, hyperkalemia, that's the classic condition, or just hypoglycemia, maybe the presentation as well. So recognize this can occur when you stop steroids. So as one of the benralizumab trials, they actually created a titration down. So you cut down by 5 milligrams every week from 20 until you get down to 10, and then every 2 weeks from 10, and then from 7.5 by 2.5 every 2 weeks, and then as you keep cutting it down by another half a pill until you can get off. And of course, the starting dose will depend on how fast that happens. But what we're doing here is we're reinstituting the body's ability to make its own steroids slowly because it's going to recognize it doesn't have enough. We can actually measure the morning cortisol. It has to be done before 9 a.m. It doesn't have to be done fasting. If the level is nice and high, you can continue titrating. If it's low, they're adrenally suppressed. You got to slow everything down. If it's in the middle, then there's a test you can either slow it down, or we do an ACTH stimulation test, which is you give people ACTH, which should stimulate the adrenal glands to release cortisol. If it goes up, the adrenal gland's working. If it doesn't go up, then it's not working. So I think we have a lot of barriers to reducing oral corticosteroid exposure. Patients are used to it, and a lot of patients say, I'm willing to take oral steroids a few times a year if it means I don't have to take a puffer every day, especially in places that are socioeconomically deprived, don't have drug plans, and so on. We've talked about the clinical barriers. We've talked about the systemic barriers. Can you actually get a referral to someone who's willing to look at this for you? And COVID certainly did not help that either. So are these patients hiding in our practices? And this is something called the Refer ID tool. It was created internationally, and we brought it into Canada as well. And this guide, these 4 questions, can have you as a clinician say, wait a minute, I want to assess these patients in my practice, and these people need a reassessment and possibly a referral. And 4 simple questions. Have you been to an emergency room or been to the hospital or had an unscheduled asthma visit, 2 of them in the last year? Have you used steroids twice in the last year? Have you ever been intubated or been in a situation where you're in life-threatening asthma and are using that more than 3 SABAs in a year? And any one of those questions should get you to reconsider the whole picture. Go back to adherence, delivery, comorbidities, all those things we talked about and say, hey, is everything being treated? And if not, it's time to think, well, maybe I should step up therapy and even consider referral, because these are the people who are highest risk. If you're going to refer, how do you refer? Again, you need to give information. The more information you give to the doctor you're sending it, the more likely they're going to triage it properly. Otherwise, I get one-word referrals, asthma, with no x-ray, no spirometry, no blood work, no idea of exacerbations. How can I triage how important that is? I'll contrast to someone, it was described to me by a specialist, we got a referral for a young police officer with 4 asthma exacerbations whose only prescription was a long-acting beta agonist. That's all they were being treated with. You know that that's dangerous. That person got seen very quickly. Otherwise, it's hard to know. So why are you referring? What are you worried about? What's the history? And what's the impact on life? What medications they're taking? Biomarkers if you've got it, other factors. Okay? So in terms of how we follow people on asthma biologics, just a couple of points. They're not at increased risk of COVID unless they have fixed airway obstruction, of increased risk of more severe COVID. Asthmatics, as a rule, have probably a decreased risk of getting COVID in the first place because ICS protects the ACE receptors. They don't suppress the immune system. We need to follow them for exacerbations, ask about asthma control. We've talked about steroid withdrawal. Make sure they get all their vaccination. You can get into that in question period if you want. Deal with the comorbidities, especially mood. Avoid drugs that can worsen, like non-steroidals and beta blockers. If you have lung function, do you do that? If they've been on oral steroids, make sure the comorbidities, check the sugar, check the eyes, maybe do a bone density, think about the other infections like non-tuberculous mycobacteria. Anything that's a concern, communicate it back to the referring specialist. I do severe asthma treatment, although I'm a family doctor, I do dabble in this. So I'd love to hear back from my colleagues who are telling me, this happened, what should I do? This is great, that's two-way communication. And adherence has to be continued. Biologics improves people's psychological distress. Well, that makes sense, doesn't it? Because they were not feeling well and now they're feeling better. Listen to Jennifer. There's just a little bit about vaccines that are important. If you're on Dupixent or Syncare, you can't use a live attenuated vaccine. Otherwise, you can use everything else. Live attenuated or MMR, rotavirus, and varicella. So that's the only small pick about that. So Jennifer, if you want to just take a moment now to describe your life now, which is up there on the screen, and what you think people should take from this.
The biggest thing that prednisone is horrible. Prednisone is bad. Get rid of prednisone. I know breathing is not optional, and if that's what I was given, and I was on it for on and off for a long time, and then on it daily. I broke my ankle, and the first thing the surgeon said to me was, "Did you fall because your ankle broke because I was on the prednisone, or did you fall and therefore break your ankle?" I slipped on ice, and I honestly think the only reason I haven't had a problem with osteoporosis from the prednisone is because I spent years doing weight-bearing walking. But my life now is so much different than it was when my asthma was not controlled. And I was never shown properly how to use an inhaler until I got to my respiratory specialist. I wish my GP had referred me way sooner because I suffered for years. And I feel that was unnecessary. I've been so lucky. I am a different person now than I was 5 years ago, 10 years ago. There's pretty much nothing I won't try except for bungee jumping, but I will try just about anything physically. Age is more of a factor now in me stopping me from doing something than the asthma, because the asthma is by no means a roadblock for me anymore. I can't stress enough that if GPs can get the proper treatment by the proper testing, by sending to a respiratory specialist if they can, that is the best thing that they can do. And I just hope that's out there for everybody. I hope that availability is there, because I do know the respiratory specialists are few and far between. There is only one in the town I live in. I actually go to Guelph for my regular respiratory specialist and to the Firestone to see Dr. Nair once a year. I'm very, very fortunate, and I don't take that for granted. I just hope other people can get the help. And I've learned so much from you, Dr. Kaplan. It's most of it's way above my head, but I can see me in everything you've spoken to today. So thank you for what you do.
Jennifer, thank you for sharing your story with everybody, because it's hard to do that. It's lovely that it has a good ending, and they don't all. So we really want to make sure, and certainly the answer is not refer everybody. That's, what Jennifer said that, I don't think that's exactly what she means. But when someone is not doing well, review everything, and if referral is part of that solution, then please go ahead and do it. Because what we should be doing is saying, are you controlled? Well, she wasn't controlled. She couldn't exercise. She couldn't do her paper route, her mail route. She had frequent exacerbations. She wasn't controlled at all. She wasn't even diagnosed officially for a long time, as you saw. So our job is really not that hard. Make a diagnosis, get people controlled with the therapy that requires it, whether it's a steroid alone, an ICS-LABA, or now the triple therapy. I said there's now 2 of them. There's triple therapies all in one device. So let's get that happen. If not, get help. And that's really the story that I think that we really want to really make the push. So from my point of view, I'll just reiterate, make a firm diagnosis. Just because you wheeze, and you think you got asthma doesn't mean you do, right? And who should you do it on? Well, the story that Jennifer said, you keep getting Ventolin prescriptions every time you get a cold, pretty good guess that something's going on. Use of steroids is a huge red flag. Prednisone is a huge red flag. It's not a small it's not a small little tool. This is a very, very potent drug that we talked about. Inflammation has to be started early. That's the treatment. And we talked a little bit about that, about using ICS formoterol rather than a SABA, or starting an ICS with a SABA if you're going to give a SABA. Okay? And we talked about the SMART strategy and so on. Right? As clinicians, as you have somebody on ICS-LABA, but they're not doing as well as you expect, you want to refer. In the meantime, you can put them onto a triple. Okay? So there's 2 triples, one called Enerzair, and one called Trelegy 200. It's not Trelegy 100, which is a COPD drug. Make sure to distinguish. Okay? Prednisone, no good. Biologic is good. Now, is there downside to biologic? Yes. Rarely side effects, not a very common problem. They're expensive. So getting drug coverage is important. But even in Ontario, there's coverage by the government as long as you go through criteria for some of the different biologics. So our patients needn't suffer for it, and we have access to these things. So please consider that for the patients. So I'll close this up now. That's my email address there if you have any questions. The Family Physician Group of Canada, the website's there on the bottom. We have lots of tools to have a look at. So Tracy, I'll pass it back to you for questions. I'm sure I've probably gone over time like I normally do. I apologize. But if we have time for questions, that would be great.
I do see we have one question in the chat, and if we can take time for maybe 1 or 2 questions. It is after 8. If anybody wants to ask a question, please come off mute.
Yes, I do have a question, Alan.
Shoot.
So it seems that what you're saying is, first of all, a patient can be uncontrolled, can have mild asthma and be uncontrolled. You can be uncontrolled whether you have mild, moderate, or severe asthma. You can have severe asthma and be controlled also. But the patients need to be look out for and refer after you've done, you've checked the technique, their comorbidities, make sure they're compliant. Those severe asthma that continue to be uncontrolled, even though you've done everything. You maxed out their inhaler, you make sure they use it properly, you make sure they are compliant, you make sure their comorbidities are well controlled. And those are the patients that we should refer, because as a family doctor, that's all I can do. I mean, you could do, you maybe, you're considered like a specialist, so you will, if you have those patients, you treat them with biologics, but for a family doctor like us, those are the patients we have to refer. Am I correct, Alan?
Absolutely. That's exactly the message. The message is that do what we can do in primary care, which is make a diagnosis, assess the triggers, treat the comorbidities, make sure they're taking their medication, make sure they're taking it correctly. You're doing all that, you're stepping up therapy, you're still not doing well, that's the time for referral. Absolutely. I don't expect family doctors to start treating biologics. It's common It's one more thing to learn. And we have enough stuff to know how to do in primary care, not to do that as well. Just like you don't treat people with rituximab for the rheumatoid arthritis. I mean, certain things have to be referred. The key thing is finding those patients that should be referred, and remember that that couple of courses of oral steroids a year is a problem, right? So that Refer ID tool is a nice tool, right? Have they made unscheduled visits to see you? Are they using more than 3 Sabos? Have they ever had a hospitalization like in an ICU? You know, and those are the kind of things that make us think about what people should be reassessed and referred. But yes, I'm not expecting anyone to be doing biologics. So absolutely.
So the reverse is true also, that somebody who may have severe asthma, but if they're well controlled on their inhaler, there's no need to refer, right? I mean, let's say if there's somebody who's on Inozan or Trilogy 200, and you know, and they have to use that every single day, or else they may get into trouble. But if they are on that and they're well, then you don't refer, or do you refer them?
I think if they're doing well and you're following the patient well and they've stepped up to a triple and it's all better, that's fine. I've got people who have stepped up to triple while assessing for biologics, you know, waiting for insurance companies who have actually feel perfect. Well, there's really not a whole lot of reason to put them on a biologic, especially at their cost, because they're doing well. Now, there's some other benefits potentially. They may decrease the use of inhaled steroids a little bit, and they can decrease some of the comorbidities, which the inhaler might not do, like the polyps and, you know, eosinophilic esophagitis and other conditions like that. But overall, no, I think you can probably stop there. Some specialists feel, and I'm not in this camp, that anybody who needs a triple should be referred because they need an awful lot of treatment. And I don't think that's the case. So I think that's fine. But as long as we're following, and that's really going to be the important thing. And you're right, the severity of the asthma is based on the number of medications it takes to get somebody controlled. If they get well controlled on very small dose ICS, that's considered mild. If it takes them triple therapy to get controlled, that's considered moderate to severe. They require a biologic to get controlled, obviously that's severe. So exactly the story you're saying is exactly the point here. And the point that we're trying to make here, I think, is don't let people suffer like Jennifer suffered for years and years before intervening. That intervention might be the right inhaler, or it might be a referral to someone for a biologic. And obviously there's, you know, people have many different severities in between. Thank you so much for your comments. Right, always nice to hear.
Okay, we have gone over. I do notice there's a couple questions on biologics. Dr. Kaplan, around side effects and if it can be de-escalated. I'm not sure if you can quickly answer those questions.
Sure. So side effects, Tracy, are very minimal. You'll get injection site reactions and things like that. You'll occasionally get some funny reactions. I had one person that got a rash from one. I had somebody else that got headaches from it. So these are sort of the nuisance effects that occur. They're not very common. They're very rarely a cause of discontinuation, but yes, things happen. So my rule about anything that happens to a patient on a medication is anything's possible. It could have happened. Try to figure out if it's something else or not. Worst comes to worst, you stop it and restart it and see if the medication is causing it. So there are side effects, but they're very, very minimal. In terms of de-escalating, it probably depends a little bit on how they got there. If there's still a trigger in their life that couldn't be removed. So one of my patients worked for the TTC. He was down in the tunnels. He did not want to give up his job. The only way I could get his asthma reasonably controlled was on a biologic. Now he's retired. And the question is, now that he's retired, can we actually step down from the biologic after some time has gone by to get rid of those triggers? So absolutely, if something's changed enough in their life, maybe it's the pet that they have that they didn't want to get rid of. Maybe it's where they live. You know, they moved from Ontario to Alberta, and dust mites were their big allergy, and dust mites are not a problem in Alberta. Maybe that'll go away. So yes, there's certainly times we do that. It was initially thought, and omalizumab did this. They said after 5 years you can stop it for a while, and the effect will persist. And that was the initial dogma with it. But actually, in fact, they found actually is not true, and people who stayed on it did better. So for the most part, we don't de-escalate. But of course, I have patients who end up stopping it because of cost. Maybe they lose their drug plan and things like that. You know, and as long as we keep trying to maximize our treatment, they can do pretty well. So yes and no is the answer. Most of the time we don't, but sometimes it happens whether we like it or not. And again, if the circumstances change enough that you believe the inflammation in the lung is actually better, sure, that'd be reasonable to consider that.
Okay, great. We are now going to close off the Q&A. Thank you, Dr. Kaplan and Jennifer, for your presentation tonight. We would like to thank our partners at AstraZeneca Canada for sponsoring this evening's presentation. You will receive a link to an evaluation form. Please take the time to fill in the evaluation because it helps us to improve our education events. Please check out our website at lungnetwork.org for more information about our programming and our e-modules, especially our newly launched Asthma Action Plan e-module and our free Pallium Leap Lung course. Also, save the date and plan to join us for our Better Breathing Conference next year on February 6th to 10th, 2023. We will be sending out registration information when it becomes available. Thanks again to our speakers and everyone for attending this presentation. Have a great evening.